said he was 60 pounds.
Adding to sugar?
Or 60. Or 60. Use the yoga stuff.
I don't, but I need to.
I should.
I want to start learning how to take my shoulders because I fucking up my quad.
You're not supposed to use your shoulders.
No, because they're like, I think because the ligaments are so like, there's no way I'm gonna strengthen it without just keep pulling. So
I mean, adrenals are
When I was rock climbing, there was this guy in the stroke truck coming up with a couple. They were just rock climbing. He was a
skinny legs and just nothing but body. Oh.
Body was kicking the ball. It was all this crazy. Come down. You could not touch that wall. It was like a ballerina on that wall.
That's how you're supposed to see.
So the coach had a coach that it's like that's what you're supposed to sound like. Because if you sound like him, you're using your upper body, not your legs. So if you keep hurting your shoulders, you're not using your lower body.
It's just because I can like.
You don't trust your feet.
It's just because I can like do this, and I'm super like flexy, and so I keep
So
the tension.
I used to use my hands too much, my shoulders and my hands. And so my coach, he would make me climb one-handed. So you had to have one hand behind your back. You could choose which one for whatever the move was, but that means you would have to let go with this hand and grab with this hand. You had to know how to trust your hand.
It's because I don't trust my feet. I don't trust in. No, I trusted my foot and I broke my toe. So.
Well, that was her falling, so.
That was you.
That's a skill issue.
It's not that big.
this is my own. Like, is feel longer. Yeah. You'll feel that's maybe solution. Yeah. Let me see. There's here.
Yeah.
Yeah.
211.
Yeah. If they have an injury and you're pushing on, like, say, you're carefully,
There's always something. No, I saw it.
sprains the definitely. So one test is like if I know they're hurt there, I'm going to actually have them pull the device. I'm going to stay off that, stay ahead of where those ligaments attack. And I wouldn't want to come up here, then I might actually press on it. I'm going to. Okay, so
There was here. She said I'm stinky. And I'm like, one day she said I'm stinky.
So, did you go to your quick run over this? I know you guys are done. Here's the key thing, and you've got it down. You know what? Tib anterior, pronatus tertius, pronatus longus, tib posterior. Here's the key. This is what I saw a lot of folks doing was not paying close enough attention. So this forearm is your vector. So imagine, kind of beat this into the ground, but so set up, hold there for your tib anterior, hold that right there. Get the patient to hold, roll the toes down. If they can't do that, then your chest is. Muscle pulls this way. I want my vector to, as close as possible, get it that pull, counter that pull. So I come clear over like this. See my elbow? And see they're like that far apart. They're not perfectly parallel, but they're not like that. They're like that. That's how you want to think when you're setting up on the test. So, and then the test is, yeah, I'm pushing down, good, let it relax. The test is like that. Muscle does this, I test it like that. Tib posterior, down and in, see if they can hold that. And then my elbow is going to be below his foot. I clear down here like this. Hold. And that's actually almost weak, but not quite. So the muscle is way under here, pulling the foot down like that. My vector of test needs to be. Now you'll find you can test them any way you want, and you'll find them real obvious, easy, but you'll miss the guarantee. Hold that right there. Put your toes down. There. Tertius. See where my vector is. Down and out, pronatus longus brevis. Once again, my elbow is below. Below is okay. That table would be the ideal table. Place it nice enough. You don't bend over so much. That's the fine point. Everybody's got that. Test these a lot. They'll make you crazy at first. family with these, but you do enough of them and you'll start to be able to tell. They're not the easiest muscles to test. Since I have your attention, let's move on to any questions on that. Somebody was asking questions about hand placement. Broad, as always, broader the better. If you're coming in here, say for tib anterior, pull your toes down. If they're sore here, a lot of times they are, and you push right on that, you might get a false. Broad contact, like so. Don't grip the foot. Maybe to get it in position, but then keep your grip away. Big broad contact. There's not a lot of not a ton of sensors on the back of the heel. Your stabilizer stand on the back of the heel. If they've got a recent inversion frame or strain, and you happen to have your hand right on that those ligaments, then you'll be triggering those. Then we've got flexor digitorum and extensor digitorum, and they're hard to test individually, but we're going to test the flexor digitorum by just having the patient grip my fingertips with your toes, and I'm just going to try to peel his toes back. Hold. Grip. So that's the thing. I don't find this being too often. Yeah. Wow. So these ankle muscles are strong, but these are not real happy. Okay. So those are the flexors. Now we'll test the flexor hallucis. Hallucis? I've been saying that for years. I'm not sure if it's hallucis or hallucis. No hallucis. English majors. So extensor muscles. Oh, there's kind of like testing the peroneus tertius, only there's no inversion or eversion. And I'll just bring up there. I'll just come in and just do a subtle test that way. It's not, I'm not so worried about a big vector thing. That's pretty good. Both extensors. Now, the extensor hallucis. Hold there. Now I isolate the first rep. That there. That's not so. Right over the center. That one locks. Okay. It's not 100%, but again, that's the extensor hallucis. Now the flexor hallucis longus. So the flexor hallucis longus attaches to the distal balance of the flexor hallucis brevis attaches to the proximus. So if the nerve supply to the brevis is compromised, then it might shut down, and now you're relying on the longus, which takes its innervation above the person to do all the toe. So this is a lot of times where we can find the cause of a lot of fasciitis issues. So I'm going to first isolate above the proximal segment. Bring your big toe down, and I'm basically grabbing this proximal segment and hold. That's good. Now I'm going to go up, and I'm going to stabilize the proximal segment and the first ray. How do you bring the distal segment down? And it's kind of mushy. So he's got some stuff going Does that make sense? So flexor digitorum, kind of test them as a group, extensor digitorum, ankle and new, for the most part. And then, but the hallucis, also, if you want to isolate that right there. That one was good. Now flex. See, this one's much better. That distal one holds. This one right here. So what do I do with it? Well, oh yeah, massage. Yeah. I'm not a golfer. Fortunately, I've never been afflicted with the disease. A lot of my friends golf, so I get old golf balls from them, and I have a bunch of them in my office. And I give them golf balls and take home and roll it around, sit while they're watching TV, roll that, break massage. And if they lose it, you know, so I'm going to just go in here and palpate hot spots. I can't see his face, but right there. So I'm treat, think globally, but treat locally. So I'm going to go right into this, brevis, hold it. Then I'm going to go up. It's hard to get at along this, but sometimes you can get. Remember that the longest has its origin way. All right, read that up. Yeah, he's got it. Yeah. These are old. This is old. I'm just palpating along this muscle group. So right in there, I'm just going to point, loading, contact, try to push, try to feel where the lymph is really fast. Remember, these fascial compartments are the fascial sheets that are the fascial sleeves around these muscles are really thick. And if fluid gets trapped in there, it has sometimes a hard time getting out. Oh, there again. Ah, there we go. Now, was this the weak one? Or were they hold there? There. That's much better. Now, we didn't, was this one weak too? Again? No, that one's good. This one has something in it. Extensor. Extensor's good. No, extensor's. So the extensor, you want to access right along the metatarsals. And, okay. A lot of times I'll find a navicular or a cuneiform. Yeah, he's stuck right there. So if you guys had foot adjustment, you guys learned it here, yes? So how do you find subluxation of the foot? Can you use a rebound challenge? You can use a rebound challenge. You can, but you're not. Can you use a static challenge? So, easiest, quickest way to ferret out things to adjust is look for a strong indicator. Didn't check you for switching, we didn't check you for question. Okay, so now I've got my strong indicator muscle, which is handy. First, I'm going to go up to these. I'm going to go right to the navicular. Get a hold of it, and I'm going to twist it out this way. Do we have a foot model? We do have feet. You guys can refresh your memory. Yeah, okay, see when I do that, what happens? Okay, so when I go the other way, traction, you can take that bone any way you want. Like if I go that way, feel it weakens again. What I did is I pushed the navicular sort of up, out, and up. So the most common adjustment, the most typical adjustment that I would end up doing on this is taking the first cuneiform away from it. A lot of times the navicular will try to drop. The first cuneiform jams superior relative. So I'm going to get right on first cuneiform, contact right there. And I get those there. Kind of they pop. So then check for. Sometimes when you do one adjustment like that, the other goes still kind of stuck right there. I'm going to go down here to its fifth metatarsal, and I'm just going to roll it out, and I'm going to roll it up. I'm going to pull it down. That's kind of hard. That's right. It's the second thing. I'm getting off into the weeds again. Okay, so what muscle am I testing? Those of you who have pens that are keeping notes, write this down. Finding this for years, this is a little side note. So that's just what muscle? Fine. Pec minor. Pectoralis major sternum. So here's something you will find. Get into meridians, just comes up a lot. You'll find that the liver meridian and the PMS. What I find often with meridian stuff, there'll be a weak PMS that responds to a contralateral second, usually second. Now that's weird, but I've seen it so many times. And of course, the liver meridian runs right through there. So that's. So when I see that, now this is tight enough. We don't have an Arthur stem. Does anybody have an activator?
I've got one.
Ready? Could you hook me up?
Yeah.
I think, yeah, I can yank on this, but I think. So, with an activator or an Arthur stem, whatever, type of device you're using, I usually come in and I'll kind of click it a few times while my Arthur stem's motorized. So I'll kind of feel it, and then I'll use this hand as kind of a listening where that vibration is coming through. And try to get it lined up, and I want to pull that cuneiform. This I come in and. So, nicely. Each word is a step. That's better. Usually they just really turn on. Now I'm going to go back here. I'm going to pull down, up, pull away, jam, go back to that cuneiform. Yeah, that. Okay. There, yes. Now there's different ways you can do that. You can use a magnet. Some people use a round magnet instead of TLing or challenging. I just go straight to challenge. You can even take your little laser thing and I have one with you. You can shine that on the different points. But if you're challenging it, you know, you're not only finding where it needs to be adjusted, you're finding what vector it needs, all in one procedure. So, well, yeah, sure. How do you turn it on? How do you work this? Now, just use that. Just use this muscle. So now we go right on that. See that? Okay, so you've still got a cuneiform. Sorry. Where's your clicker again? So I'm going to adjust this cuneiform. Not cuneiform. So keyboard. How many bones in the foot? Per foot. 25% of the bones in the body are in the feet. 26 bones per foot. 52 bones. We got 210 bones roughly. So, and each one of those bones has an articulation with tons of chemoreceptors. So, even though they're small, are an enormous source of after. Sometimes after. I wouldn't ever spend this much time on foot office. Okay. Right on that, yeah. And you can use these all over the place. You can use them on. If I wanted to test his pulse points, for example. So right there is his distal pulse point. So, I mean, there's lots of ways you can. It's a nice little. It was heart song. So, anyway, got that foot dialed in. I was using it instead of TM. No, I just let when the light goes there, if there's a problem there, it'll kind of show up in the system. It's getting kind of airy-fairy out there, but it works. On different, but I was on specific parts of this foot, like you can use it on again. Like if we did it here, and I could also come here on the indicator muscle, lightly touch that. That's his personal. To go deeper, or theoretically, I don't go by that, but more so small intestine. So then you kind of, that's another flow chart. So so flexor, digitorum group, longus and brevis. You're kind of testing them all at once. Extensor, digitorum, extensor hallucis. Let's stay with hallucis. Extensor hallucis, longus, and flexor hallucis, longus and brevis. So tarsal, I've got some slides on tarsal. You guys are all familiar with tarsal tunnels. It's like carpal tunnels here. And that's what you'll see a lot with, if the arch is collapsing a lot, it's compromising that structure through there, and you end up with a CDM. Any questions on these muscles? Because we're going to do these muscles next. Right? That was probably more. We didn't do this. This one didn't have much trouble.
No, but I definitely felt the ankle.
Walk around.
Short on my
Is that, was that my name? No, that was not my name.
And then this one's just kind of like extend your toes.
It's like the 2:30 mark. I'm not.
Yeah. That goes
Oh,
really quickly.
it's hardcore. Yeah. I haven't done laundry. Shirt night.
Especially when you start
was behind, like with your body, so it feels that way. Yeah. Just
It's definitely, you've got a superior person.
which I think is so cool. That's what I broke my toe.
Yeah, like all in the.
Like, put it, like, twist it, game it.
I was like, wow.
Because I was like, and then when the offer came, I was like, brevis longus extensor, flexors extensors. So it was like, grip my fingers, pull it out. So I'm going to stabilize big toes.
I don't think I've seen that one.
Stabilize big toes. First joint. Toe.
I think this is
So these are good. So this one first.
Okay.
And this one. That's pretty good. Okay. So that was testing. Yes. Okay. And so your socks going to connect for such.
Yeah, I don't know why. It looks so funny.
And then you can do the extent of the groups. Yeah. And then here, right? So this one, you'll first stabilize here, and you'll kind of use this finger to basically.
Yeah, right now.
These fingers are kind of up there, so you'll like pull it higher.
Right.
And then you'll stabilize here. Where's my wrist? They're both messed up. They're cushions. Also, definitely like this way. Yeah, you go kind of but you just want to
Well, I usually don't, honestly, I don't adjust the ventilation too much. I usually adjust the first QA off. So you come off the venticular, the first QA form. So it's just
Oh,
like,
so then you just do that.
I do a double wrap with my little fingers there. And I try to get some traction this way so that the vector is sort of fully. So,
Okay, it's here. Let me push it out.
And then now you switch.
Yeah. Get us into a forest. Whoa, oh God. Go away.
It's always one of the two, like when I do some shapes, those shapes,
And then I was like, there's nothing I need to know. And then he's like, he's like, you need this. And I was like, I don't need it. And then he's like, swearing with me. I was like, dude, we're not doing this. I was like, I need it.
Okay, so when you're flexing it, you have to just going really extending it.
And then he walks out of the bed. He tried to start the conversation. Go back to bed. And like, obviously you two need some time. I'm gonna leave. No, we'll talk about it.
Same thing.
Because I thought we were divided.
Oh, and then for this one, let's see. Yeah. Yeah. I thought you were two different ones.
This one is.
Everyone was like,
Yeah.
the trouble survived. You need to see that. I left it.
Counting now.
hey guys, everybody's got the feet. We found wheat. We found a bunch of wheat stuff. So go back to the feet again tomorrow because after we do the low back, we're going to tie it together with what goes on the feet. So we'll find more foot weaknesses once we get into our backs. I want to show you something really quick, then I want to do reactive muscle. You got 2 hours? Everybody know?
It's 12:52, so I'll
So
I want to do reactive muscle, and I want to try to do this DRS thing and get it out of the way. It's kind of fun for me. But yes, I think I might need somebody. I'm pretty strong. Who had weeks sacral spinatus? Anybody? You did? That's right. Both sides. What'd you have in the teeth? One foot was off.
Yeah.
You want to lay face down? Sure.
What?
Face paper. So, we don't know. You might have fully gone. We don't know. We don't really know. We don't know anything that's going on really, except that we do know that we had this way, like that. And when you test this, make sure they'll want to turn this way, and that's okay. You test them that way to make sure they're close to neutral. Right there. Okay. And then come up to the other side. And okay, so there could be any number of things going on that is causing those to be weak. Got a lot of trigger points along here. But I'll go back to that. So I'm thinking now kinetic chain, this kinetic chain thinking. Or if you want to think in terms of like the myofascial, anatomy training type thing. So the hamstring. Oh, that was good. So one hamstring's weak. Okay. Let's see about the gluteus maximus. Hold that there. That's weak. Bring this up here. Oh, okay. So we've got a big difference there. Now, did you have okay, so is this tendon? It's not. Open this. You never know when you. So I'm just stirring this up. You can call it challenging, TLing. I'm just stirring it up, bringing it up on the screen, and the brain's, conscious awareness. I'm just going to give that a little challenge there. Now bring this up again. Okay, good. So now a drop navicular, I almost never adjust a drop navicular supine. I usually adjust the first supine, often navicular. But if I need to adjust the navicular, I will do it prompt. And this is how I make my comment. I'm just going to challenge her navicular. That actually went. Challenge her navicular. Now come up this way. Arms back. And hold. For the difference. You see the difference? That's huge. I mean, I didn't really send you hardly anything. That's huge. Both of those were weak. Back off. All I did was fiddle with it. Yeah, let's see. Sound like I'm doing an infomercial, but that's back on. Strong and clear. This was weak, still weak. Okay, So that's weak again. It did turn on temporarily. Now let me see if I got it. Maybe I need to challenge it again. Just kind of pushing it there. Yeah. So I had lost my challenge. The challenge was kind of like an adjustment wasn't enough. So now I'm going to adjust it for readings. Okay. Yeah. You should ask the patient. Not licensed in Arizona, so if this goes badly. Never been. Not my real name. Not even a chiropractor. Now, this adjustment is touchy because a lot of times the ankle wants to invert. I don't want to put inversion stress on the ankle, so I'm going to bring it down there. Exactly. Now, I could have done that with a arthrostim. That's still not right. I think you've got some O and I. What's that? Yeah, try that again. Yeah, so I'm going to do, is it okay if we just feel this? Okay, so this is a classic O and I. This is down on the lower part of the glute max, where I often find O and I issues, right in there. Right? So I'll go a little lighter. But this is that wanted to feel the marbly, the BB under the bacon. Yeah. Who wanted to feel the BB under the bacon? Al did. Al, you can tell Al about it. Now take the flat fingertips, like that. Subtle. Right on the bone. You feel that, right? You don't feel that? There it is. That's where you do. And you feel it. Yeah, oh yeah. So, I mean, that's the thing. You guys take blood pressure a lot, the old-fashioned way, or you guys use machines? What? Talk to do. Oh, good. Isn't it amazing though how hard it is to hear that kind of? I've been doing it for almost 40 years, and I do CDL, so I do it all. Not a day goes by I don't think like that. But I find it so tricky to hear those subtle little differences in heartbeat. Listening for the murmurs, listening for the. I'm always almost glad when a patient comes in and says, "Yeah, I've been diagnosed with a murmur." Oh, good. Now I can hear one that I know for sure. Cool. So I'm gonna treat this. What I do is I just go right in on it. Oh, sure. And then that's where I'm gonna treat. This is kind of different. This is kind of that's actually kind of that's actually.
Everyone's tender here, right?
You guys will probably treat that way right in flat fingers, right in. Basically, that's how you treat it. Okay, so go ahead. You're a total scared.
Just wait for them to go. Yeah, I mean, she was
No.
yeah.
Okay, so last pass. Oh, you were. Okay. It's really tender. It should be less as I go. Tell me what it is less. So there's no real traction to my pressure. It's just straight into the bone. This is old-fashioned. This is the very first thing that George Goodhart discovered that led to AK was O&I. And it's still one of the most valuable tools that we have. It's different in that trigger point release, you're in the muscle. You're in the tangled trigger point fibers of, this is tendon periosteum. So it's similar, but it's different. Hold there. Yeah, that's rock solid. Now I'm going to so if I miss something in her feet, which I did, I'm going to pull that dam form away from there. Now, those you have trouble really getting a grip on the feet. Get you one of those hand squeezy exercise things, and just start, put it in your car or whatever, and just every so often when you got time, just tire out your grip muscles. And strength will come up. No, that's good. Okay. So I wanted to tie that together with how important, how profound. Yeah, she had one eye on her good max. That foot was throwing an entire smile. So, any questions on feet before we move to the next? None? We will go back to feet tomorrow and spend more time. It takes a while before, and we'll be able to tie it in with go back. So somebody, anybody, I want anybody up there that doesn't mind being tested in a variety of different ways in the next few minutes. Somebody, anybody. See if I can find my. I want to find that kind of. We'll do this, but where's my reactive muscle slides? Okay, so I just we got really into the triad of spraying last session, right? Primary muscle weak, usually this been trauma, either past or more recent. That muscle will respond to O&I. It'll respond to spindle up. It'll respond to GTO manipulation, very likely. Then there's the antagonist to that muscle that's been injured or chronically strained, and that's going to be typically hypertonic and sort of fascially congestion. That muscle will be strong in the clear. It will weaken after a quick stretch, and it'll respond to epirage, fascial flush, whatever you want to call it. It will also respond to, especially like hamstrings, big long muscles, will respond to PNF stretching. The third component of the triad of strain sprain is the synergist primary weakness. Now, what will happen with and that muscle will respond to strain counter strain. That's how you find it. And what you do is the muscle will be strong in the clear. You'll test the muscle, and then you'll have the muscle go into full contraction. You'll just hold the muscle belly for a little. have it, you contract it for about 6 seconds, and then you hold it. Then you retest it. That is a synergist to the primary weak muscle that needs spindle damage. It's set too high because it's been compensating for the primary weak muscle. So a good example, do you have any issues with your shoulder? Maybe we'll find something there. So a simple, straightforward example, see if we have one, would be a delt, which is strong. You check your posterior delt, which is not strong. Check your anterior delt. Remember this one? And that's pretty good. So in essence, the 3 divisions of the delt could have a strong anterior delt, and the synergist, the posterior delt, could be. Okay, I'm sorry. The weak muscle could be the posterior delt, and the synergist could be the middle or anterior and the anterior delt. So those could be involved in a straight situation. The antagonist to the delt is going to be a number of things. Lat, to some degree, pec. So lats. So, but right now that's strong. I mean, I'm sorry, that's weak. So let's just simple approach here. We're just going to see that spindle up. Turns right on. So it needs turned on. Now, the anterior delt will have you hold about 6 seconds. Let it fully contract. And then test this again. How's that? Now, another way we could do it, we could have you there, still weak, and have you TL the anterior delt. This is a set that probably easier way to see that. So we're going to spindle this one up and this one down. This is reactive muscle, and it's a very simple approach, but it's something that's very very effective and often overlooked. And what tells you that you might have a reactive muscle is pain with motion. Often, yeah, it hurts a little. Even though that's turning on, and that's the okay, so we'll test that, and then test this again. It's good. Now, I may not even have to turn up the spindle on the posterior delt. I might do anyway. Now, what's an exercise for posterior delt? Because you'll find these so often in patients. I think like anything like this is going to access the posterior. But there's an exercise where you can use cables, like light cables, pull point way down, and you pull like this. It's almost like you had 2 big barrels here, and you were wiping the side of these barrels. And that really accesses that posterior delt. Learned that from a bodybuilder here. He had shoulder problems, and he came up with this really way of rehabbing it, and that was years ago. Now stand, please. And it really works. Now that's strong and clear. The lat. It doesn't like it. So that muscle needs to actually. Now the lat is a pretty thin muscle. So I'm just going to go up origin. Just kind of get that good irony now. Stretch. Stretch. Back to this. So that's basically what it is. Now you can find this anywhere in the body. often a synergist, say biceps femoris, a synergist would be the medial hamstrings. Sometimes they're in kind of in series. The glute max and the biceps femoris work genetically together. So you might have a tight, I see this quite often actually, a tight hamstring that's compensating for a weak. So you can get the glute max firing and work it again. But every time this fires, it kind of interrupts, it decalibrates the main muscle you're working. So you spindle it down to get it to reset. That's reacting muscle. Now, where is my... So, any questions on reacting muscle? Back we go. Okay, so the I don't want to mire down to this too much, but so we've talked about dural torque. We've talked about looking for where the dura attaches, upper cervical, sacrum, and all. Dr. Gerhardt came up with this thing somewhere along the way. He felt like this had a lot to do with held trauma. And these reflexes were identified, these what are called neck righting. There's the visual righting reflex, which is right here, which is really like a cranial sutural point. You treat it like a cranial point. You've got the labyrinthine, what he called the labyrinthine reflex, which is just inside the mastoid, basically right by the apis. Then you had the receptor joints, the mechanoreceptors in the upper cervicals. So it overlays on what we know about ocular lock and torque and where the dura attaches. So these are like fine-tuning things. If somebody keeps switching or coming back with the same patterns, and you've done all the other stuff that's pretty obvious, this is a good place to go. And the way you test for it, here's the pelvic reflexes. The ones right next to about S4, above the coccyx. It's right there where the sacrotuberous ligament attaches. And then right on the pubic bone. These are all little sites that read tension that are helping the brain know that where its different parts are. So this had to do with labyrinthine system. I don't get mired down into too much, but what we'll do is we'll go to the, there we go. So the way to test for it is you test flexion and extension homolaterally, flexion, extension, contralaterally on both sides of the body. So you're testing on 8 sides. Oh yeah, 8. So there's 1, 2, 3, 4, yeah, 8. And then if one of those weakens and the muscle doesn't have a problem of some other kind, then you go to these reflexes and you TL and you find out when to do the body. Or are these good still? You'll be saving these. So, first you test the muscles visually to make sure there isn't a problem that needs to be addressed. so those are good. Now, first, same side. Push apart. Now, contra. Push apart. Okay. And flexion, extension, flexion, flexion, maybe not. Flexion. Okay. So she weakens on flexion. Now, I want you to breathe in, because there is a respiratory component. Breath. Breath in. Okay. Breathe out all the way. So she strengthens on the exhale. So this is where it gets tricky because I need a muscle to test. So I'm going to go find a muscle that's. I want you to touch right with the lateral. I want you to go to here. Breathe in. Okay. So I'm going to treat that reflex on an in-breath, and I'm going to treat it just like a cranium. Or it's almost like a bending point. Just hold the weight. And breathe in. And again. I'm putting pressure as she breathes out. Start to pulsate. So you'll see flexion. Yeah. Extension is good. Yeah, extension is good. 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 So just that one. I'm glad I kept it simple. Well, those are the neck riding movement. Because usually you kind of go to the hand side, like that was the left hand, and it's the anterior flexion, so you kind of go for the posterior at this point, or I could do a neck riding. That it's all spelled. If you take the time to read through, it's all kind of spelled out in the notes. Get a chance to workshop it. But that. Honestly, a lot of times I think if you do good upper cervical and sacral pelvic work, you'll clean up those things at a time. That's why you want to do all the other stuff first. And, anyway, it's considered another kind of switching. Okay, let me go. This is my thing. So we'll go back. We'll run back through these. So here's the reflex. So okay. So if I'm testing contralateral extension, both the left arm, the right leg, I would treat the upper left and the lower right. If I was, okay, there's extension homolateral, I'm going to treat on the hand side, both sides. I'm going to treat the reflex on both sides. If it's flexion, I'm going to treat riding reflex, and we didn't check her ramus reflex, but it's strengthened, so we don't need to. There's what we did on Alyssa. So I went to the left visual riding reflex, and we can just test. Let's just have, I'll have you Honestly, I've never used these in my practice. I just use tests and then we want to read that. And just have the patient hold it. The test. It's interesting that you strengthened on expiration. Perfect ever strengthen. Make sure you work the switch. You're so much clearer since you got on this. Yeah, you're clearer. It's like less. So another way to screen, this is the original way Dr. Goodhart found this, was people would have weak muscles, but they would strengthen when they closed their eyes. And this is how he made the connection with trauma. Often you would find a tibia anterior on one side and a long head tricep. Just did that. We held it for 30 seconds on the phase of respiration that we needed and felt for the pulsation. And I felt it on about the third breath. Back your muscles. So this is how you treat them. You spindle down the, we already did these. Okay. Now, how much time do we have? Okay, 1 hour. So we can jump into disc. We'll do that. We'll finish up with lumbar disc. Does anybody have, they know, like disc injury, like a lumbar disc injury that they're aware of? So you guys learned a lot about, I'm sure you learned a lot about discs and how they get damaged and whatnot. I was first in practice. They had so drilled into us all this stuff about being careful with herniated discs, because if you adjust them, when they flare up, you get sued. And I actually know 2 people that got sued for adjusting someone and making this worse, blah, blah, blah. But anyway, I was so paranoid. Every time somebody came in with acute low back pain and any pain down the leg, I was sure it was a disc, and I was ready to send them off for tomorrow. And then bit by bit, I started to learn that a true disc, and I've seen a lot of them now over the years, but a true disc herniation will be really pretty obvious. It really fits the kind of classic presentation most of the time. And I see a lot of piriformis syndrome, which will act like a hot disc. But there's a way to tell the difference. Sometimes they have both. Piriformis syndrome causing frank sciatica is probably more common than the root problems with I see so much fewer disc surgeries being done nowadays than I used to. They're just rarely done. Laminectomies, now they use injections, they do traction, they go to great lengths to avoid doing surgery. Where in the 80s, early 90s, yeah, they just go in, and a lot of times they get good relief, but then the problem come out. So anyway, some misnomers about vertebral discs is they're not a thing so much as they're just an uncalcified zone in the spine. If you made a spine completely out of the fascial matrix, like we do when we're forming in the womb, and then you decide, okay, I'm going to calcify every other zone, that's what we end up with. We end up with vertebrae, and the uncalcified zones in between become the disc. So the fibrous matrix, the myofascial matrix, or the fibrous matrix that makes up the disc is continuous with the vertebral body. It's just that it's calcified. So it's not the way I was taught, Richard. I was taught the disc was a thing, and it's like, and patients think a disc is a thing. It's like, why can't they just take that out and put a plastic one in there? There has been attempts to come up successful yet, maybe someday. But so that's, I think, the first thing to kind of realize, that the disc isn't a thing, it's an uncalcified zone in between. And its purpose is to create cushion and, to create cushion. So the integrity of the disc determines how well it holds water. And so as that finely woven matrix of fibrous tissue starts to fray and separate and wear down, it can't hold water as well. So the disc loses its ability to hold water bit by bit as an image. Now, if you wear the heck out of it and you have bad biomechanics that's causing too many forces to concentrate in these different areas of the spine, then of course you're going to wear it out a lot quicker. And if you wear it out bad enough and you get fissures, you can get disc creations and prolapses. But most of that happens when you're younger. Like, you guys are prime candidates for disc creations. I'm not so much. I don't have. I'm kind of past the age where I can have other problems. I can have worn away discs and fragmented discs, but I'm not going to have high chance of blowing that. So that's kind of some. This picture is really kind of misleading because it looks like it's just a nice big old hockey puck sitting there, right? So a disc, it was thought, I was taught in the 80s, and they said, well, discs have no pain sensors. Well, that's not true. They discovered in the 90s that they do, in fact, have pain sensors. The outer 1/3 or so of the disc is fairly well innervated. But it's not super well innervated. So you don't get a lot of pain from the disc. You get pain from the swelling around where the body's trying to heal, or the irritation and trying to limit the ischemia that's happening to the soft tissues. Piriformis syndrome, Janet Travell. Has anybody heard of Janet Travell? She's been dead for years, but she's the person who invented the whole concept of myofascial trigger points in the early 60s. She's literally wrote the book on trigger points. Nobody ever talked about trigger points before her. She gave trigger points whole therapy. But so I find these all the time. I'm almost relieved when I have somebody with sciatica with piriformis syndrome, and oh good, they have a frank disc herniation. It's always messy. So first 2 decades, third decade, by your 40s, 50s, 60s, and beyond, the disc isn't as likely to hurt. 20 to 50 is where you see most of them. The weird thing is, over the years, lots of studies have shown that the degree of disc derangement or breakdown on MRI does not correlate at all well clinically with patient symptoms or function. So that's why you see a lot less surgeries and a lot more. Everybody is referred to PT. And then if that doesn't work, well, then they inject and with anti-inflammatories. And if that doesn't work, well, then more PT and more drugs. Pain management. That's how I see it being managed in mainstream medicine. Anyway, Okay, so anyway, this is stuff you guys probably already know. The disc is designed to twist. It's very capable of twisting. It's like like a basket weave. But at some point, the fibers start to break down, and if they can't heal quick enough, where they're twisted more than they fission. Disc gets its nutrition through sort of an oozing from the end plates of the vertebrae. It has very little blood supply once you've reached maturation. Any disruption of fluid in the compartments around the disc in the spine, like intermuscular layers, can sometimes cause disc-like symptoms. ICV is a classic. We talked about that last time. Ileocecal valve, if it's stuck open usually or closed, it will interfere with the right iliacus. And when the iliacus is turned off, often the piriformis and some of the other muscles actually tighten. That's where a piriformis syndrome comes from. So a lot of times an hot ICV will present as a hot disc. Sometimes acute ICV will present as an inflamed shoulder, like bursitis. Pretty common, actually. I've seen quite a few. Anyway, so disc herniations are a pain. Other studies have shown too that they do MRIs of people who are asymptomatic, and they have all kinds of disc injury, all kinds of disc tears and stuff, which aren't even showing up. So that's why we don't see as many surgeries. Plus, the surgeries don't usually work very long period of time. Part of the aging process, if you buy into that. So anyway, I have a very gentle. If you get somebody in with a hot disc, and especially if you get somebody that's had an MRI and says, "Yeah, I got a disc herniation," this is a great, safe way to treat. Here's how you test them. Somebody, let's find one, but I can demonstrate. You know, a vertebrae, a vertebral subluxation, no therapy locals. I always like several things about looking for my indicator muscle. In there. Now, will you take one hand and just tee out? Come up this way. She TLs at L4. She TLs at L4. Now, that would led me to think she has a subluxation. Now, if she has a subluxation, it should dynamically challenge and statically challenge. And do an inhalant. So I'm going to challenge her vertebrae this way. The other way. Breathe in. So I'm going to correct that first. You should stay from here and get a little traction here. Like so. I'm going to have you breathe in. My thumb is on the left side of the spinous of her elbow. There we go. Now TL at the end. And a little bit higher. So that's not shown. Now I want you to keep both hands on. touch above and below. Like, can you get on that L5 spinous? Have your fingers touching. That's indication good. Now, I'm going to take your hand. Okay? I'm going to go to the side, to the TPs on both sides, and push together apart, and I'm going to go to the spinous. I'm going to find out what's positive. That's how I'm going to make my. So I'm going to spread apart. Here, I'm going to spread apart this way. So I'm going to push together. And I'm going to push together. Okay, so she needs both. So it's like she's like this. So spread apart, breathe in. Breathe out. So push together, breathe in. Breathe out. So she's going to inhale on the right, spread apart, exhale on the left, push together. It's almost kind of a relief. This is a pretty straightforward protocol. Breathe in. Breathe in. Breathe in. Be two more just like that. That'd be fairly. Now, I'm going to have to breathe in and breathe out. Breathe in and breathe out. Very good. Two more just like that. Now, can you two-finger key out that again? Now go up a little bit. Make sure we're not missing. So I'm kind of good with that. Relax there. You can okay. That's looked like he hesitated. I would make sure it wasn't sore. So let's. Oh, another way to screen for that. Sit up for a minute. You got somebody with some sort of a hot low back, and you set them putting the most stress on their spine in this position. And that's why. But if she was weak there, I would have her push down the contraction of the body. That's a really good screen. Any kind of compression. Had any low back? Somebody had low back. We had the thing, but
I'm so.
low back. And you had weak safest analysis.
My fingers came out, so it's fine.
You always put nothing really obvious. Right now, tell your go back. That's way high. You injured your back. Let's go ahead and read this. I think, even though there's nothing to be that your favorite.
Yeah, I brought it over.
Okay. Take it ahead. So same thing. It was right here, I think, right? So can you tell that? Now breathe in. So there's an inspiration phases. So I'm going to challenge this way, challenge this way. Breathe in deep and hold it. Okay, so I'll correct that first, like we did. So go ahead and breathe in. Let go. And again. And it's really tight. And one more time. Try that again. Challenge again. That seems to be relevant. Now, can you do it two, like we did, no, like this did, just kind of like bigger. There we go. This way. So, same thing. I'm going to go together. Heart. Yes. Breath in. Yes. Okay, so heart on the other side, the left side, and breath in. Okay, so that's the same. So both sides need to be, she just needs to open up in there this way. So I'm going to do them both at the same time. Breathe in. And it goes, blocks that. That's, I'm going to, see, she's pretty, got some pretty good lordosis score there. I'm going to take the blocks and, like, both of them in under that front pelvis, just to give her, now her sacrum can kind of rock back, and I can use this as kind of a fulcrum to kind of create some traction. So breathe in. And breathe in. And breathe in. You kind of see how blocks work. Okay. Breathe in again. More breathe. See, they can be pretty acute, and they can have twisting. There's no nothing rough. TL. I'll go up a little segment to see. So that's good. That's kind of the long, short of it. Hopefully. Yeah, I mean, there's things going on in there, but that's something you can do that every day. Always do that every day, and it would hurt you. Now, you don't necessarily want to be doing this every day, but any questions on that? Yes.
So with that whole thing that you were doing, are you checking for a lumbar puncture?
I'm checking, yeah, theoretically. I mean, I'm assuming that I'm addressing the disc arrangement. The disc is kind of like too much pressure on one side. Like this was kind of wedged, so we did opposite.
So
Well, if they're having sciatic symptoms, and if they don't get better, they're not showing. I don't waste too much time. If I'm not seeing pretty measurable results pretty quick, then I don't have issues anymore. There's an entire industry out there designed that their insurance will pay for it. I'm pretty sure. So, but in the past, I used to babysit this for months trying to keep it back. Okay. So, these are muscles like these are rectus, tibia anterior, not so much. Hamstrings, piriformis, psoas. Those are muscles I always use for assessing the liver. So handy. They're right there. They're face down, and they're also innervated by the nerves that you're testing. So, tibia anterior, of course, the L4. Tib posterior and gastroc for the finest one. There's a correction. You can go on the spinous. This comes out of SOT. Any of you familiar with SOT, sacral occipital? This came from many years ago. If they have hot low back and determine that they have a hot disc, check their ICD. Chances are they've got something going on. Look at their inflamed toxic guts and livers. You'll get way more mileage out of correcting those things with these kind of chronic disc. Inflammatory events, then you will, a lot of them are mechanical treatments. So, of course, don't forget to rule out big bad ugly stuff. Prostate, bladder stuff. I had a patient earlier this week, a guy I really liked this guy. Guy's in his 50s. I've known him for years. His wife, I've seen him once in a great while. Drifts in. Comes in, hadn't seen him in a year and a half, and he's got signature presentation for esophageal. Because I've seen enough cases of that over the years. Comes in, and I'm praying that he just has bad news. Send him off for a scope. He went to his primary care doc a year ago, who I know, and he poked his belly and said, "That feels normal to me." And his symptoms have done nothing but get worse. So it's, he thought I could help him with some enzymes, dietary stuff. You need an ultrasound, and you need a full workup. So go back to that doc in the box that you barely seem fine to him. Tell him that you continue to have symptoms and they're worse. And so I'm waiting for that. But I lost my cousin to esophageal cancer, exact same presentation. And I lost my youngest daughter's husband 2 years ago, almost 3 years ago, to esophageal cancer, at the age of 34. So it's a subject that's very relevant to my life. So don't, I know when you guys are in school, they drill it into you that every other patient's got cancer or something. It's not true, but that's how I was when I got out of school. But then most people that you're going to see don't have these things, but you will see them. I had a guy who kept coming in, this is years ago. He kept coming in with this intense first rib, CT, shoulder stuff, and I did everything I could and adjusted him, and Marvin was his name, Marvin, and smoker, and he was convinced that he just was out of joint. I'm out. Finally got him to go get an MRI, and he had what's that, Pencoast? He was dead. And so, and I don't know how long I've been treating him for. He had this for probably a year. I see periodically for. Wasn't getting better. Should have said it sooner, but yeah, you will see these things. the set implication, where are we at on time? Yeah, 35 minutes. Oh, any questions on that before we move? So, two main things you'll see in LOLAC problems is this engagement and the set jamming. The set syndrome, the set imbrication, you might call it. But it's based, and most of the time when we're adjusting the lumbar spine, we're manipulating the concentrics. Very, very complex synovial joints, a lot of innervation, there's synovial linings. They're a way more complicated joint than the disc is. And they're loaded with pain centers. So in 8K, we have this kind of classic way of this is another easy way to treat. I just adjust them. If somebody comes in, they got a jam cassette, I just adjust it and then I work on the muscles. But you guys are familiar with Kemp's test? Kemp's test and what's Lessigues and Kemp's are the two biggies, right, for lumbar stuff. So Lessigues and Braggart's, those two old tests are mainly to heal a sciatic nerve that doesn't want any traction. Kemp's test is going to show up positive with a jam cassette. And you can have particular pain and nerve root irritation from a facet. And it can be just as intense. It doesn't seem to be quite as much of a classical presentation as a disc. See some, it can be pretty acute. So your classic so your classic postural distortion with a disc is going to be, this is your classic disc. As long as they stay in extension, they're not compressing the disc. As soon as you go into flexion, the disc is compressed, and the rotation is increased. So they're going to be either like this, and classic facet, they're going to be pretty straightforward. Sometimes they're like this. Check you for a second. So with the AK protocol, okay, so classic. Actually, face away from it. So your classic just come in here, put some pressure, you have them let them passively go into extension. If it's a jam cassette, it'll be painful. Sometimes they won't let you even go there. Okay. So I'll go up and down a few levels, and that actually may not have that. So somebody, you. So I'm just going in and okay. Now give a little bit of lateral. Okay. Oh, I'm sorry. Yeah. And that's okay. Okay. Here. Here. Okay. That's it would be a mildly positive. So then point your back. Now, what we use the TFL because the TFL is very sensitive to on with them. And strong and clear. Now, on the up, and just let that kind of, I'm going to give that a little, oh, I'm doing a rebound challenge. There. Let's try this here. So strong. Ah. Okay, there we go. So, now, if it's weak and it's clear, let it relax and give it a little and push up. That turns on. That's a positive. If so, I'm not there for you. So where our box go? And right here. So I use Kel right about where we. So go up a little bit. Finding what level I want to block. Let's find that. So that's kind of where we start from. So what I'm going to do is I'm going to take the wedge and I'm going to wedge it in just at the upper part of where that is. I'm going to bring this up here. Now that's at about L3-4. So there's a slide here showing. So if it's L4-5, you have your leg about here. If it's 3 or 4, you kind of come out this way, trying to access that. So I'm going to be out about this way. And just let that relax. Now, usually the patient's weight on the blocks is enough to hold them. Okay. That got the ankle a little deep. Got it. Now it's going to tap the TL. So that seems to have gotten, that's a pretty straightforward. Any questions on that? Now, in regular chiropractic, naturopathy world where we do diversified style adjusting, we would find the level of the set that was fixated and we would just do side posture adjustment. You don't like doing side postures, or maybe the patient's too much pain, or maybe they're too big or too fragile. That's a good option. You can also do those facets respiratory, which is a really good idea if you someone who's got osteoporosis or kids. Hey, you can always do more. You can always turn up the intensity. So use techniques that are, if they're effective, they don't need to be aggressive. Block. And here's kind of a thing to kind of see L5, L1. Category 3. We got time for category 3? What time is it? How much? Yeah, 30 minutes. Oh, I thought we just had 32 minutes. Oh, great. 49 minutes. So let's cover this. We're going to be we'll be in good shape tomorrow. Category 1. Somebody tell me what a category 1 is. Two-handed TL. What's the posture? What's the posture of presentation with the cat? Kind of twisted, yeah, like, so, category 2, head and feet are on the plumb line, pelvis is off to the side. That's category 2. Category 1, head, pelvis, and feet are on the plumb line, but your torsion around it. Category 3, pelvis, feet are on the plumb line, head is the body and head are off to one side. That's cat 3. Cat 3 isn't necessarily worse than a cat 2. It's different. It involves the lumbosacral disc. It's more than anything, it's bad relationship between L4, L5, and this is, I don't necessarily agree with severe versus, you can see these being pretty bad. So this indicates that it's a level of severity, but it's really not. They're just 3 different ways that the pelvis can get that. This is cat 3. Now, the cat 1 is a 2-handed TL. Cat 2 is a one-handed TL. That makes sense, right? Cat 3 is a no-handed TL. It will not TL. You have to go by posture and challenge. Right? It's a little tricky. Well, we teach it later in the program. Another thing that kind of came out of SOT many years ago. Dr. Goodhart's father and Dr. Goodhart were both close friends with Desjardins, the guy who originated SOT way back in the day. So they incorporated a lot of SOT thinking in the early days of AK. Anyway, glial crease and feet are on the plumb line, structures above lateralized. Often, if you're off like this, often you have disc derangement. Category 3, you can also have a herniated disc or acute. You can also have an acute facet. But AK, we're kind of looking at it from an AK perspective. So the way to challenge it is somebody come up here. We'll just go for it. I'll go through these. Somebody bring themselves. Someone with a category 3. Yeah. Tomorrow, please report. I want to move that high-low down here so we can use it. Can you wouldn't stand for this? Shoes up. Or keep them on.
They're barefoot shoes.
Oh, no. Stand here, face. I don't see the classic cat 3 posture. Don't see it. But that doesn't mean we can't. So the I always find is it'll be tender as heck right here at L5. And it'll often be tender out here into the glutes. Both sides. Now, if I was being super thorough, I would tee out and stand for cat 1, 2, and while I was at it. So I got 2 choices. I can press L5 right to left while I lift from the pelvis up. Challenge. Or I can go the other way. There's only 2 options. If you have a classic cat 3, a lot of times the hamstrings will be weak. That one's kind of weak. This one's not too bad. Let's check your rear. Okay. That's a pretty good one. So I'm going to use that. So I'm going to I'm going to press her L5, right and left, and lift her pelvis about 3 or 4 times, and retest my gut levels. I'm going to go the other way, just beyond ring. Okay, so with the blocking, so I tested this way, right? So my first block goes straight in, just like cat 2 blocks if she was laying on her back. But she's prone like cat 1. So cat 1 and 3 you treat prone. Remember this 3 attempts. Cat 2 you treat supine. So I get a positive challenge this way, block goes in this way, block comes up this way. It's kind of like it's like a cat 2 blocking with the patient. Now the difference is I will move this block. I'll start out just about almost straight across and down a little bit. And I'm going to retest. Now usually the hamstrings will turn right on when you first block it. I'll also monitor tenderness. Is that tender? Yeah. Is that tender? A little less, okay. So I'm going to move the block down, sort of wedge it down this way. And I'm going to retest here, because this one was kind of, that was, this one is good. Now, is that any less tender? So I'm going to move it down just a little more until the hamstrings weaken again. So it's kind of crazy, but that's what I do. Let it sit for a little bit. Right now it's correcting. Blocks are correcting. So they're correcting the cat. Go ahead and breathe in. Out. So I would probably be doing pressure points while the blocks are working on her paraspinals. Might take the percussor and lightly run it on the same group. Kind of speeds up the process. These re-strengthen. They weaken and then they re-strengthen as it's cooking. Now, when it's done cooking, i.e. correcting, both those hamstrings will go. And that's when the correction is done. Dr. Francis used to take the 2 hamstrings and test them at the same time. The thing is about that is that if they're acute, that might be a bit much. Listen. So we're cooked. Wow. How do you know if you got it? Well, you just re-challenge it. And re-TL. Challenge, challenge, challenge. Doesn't show. Now, let's make sure she doesn't have a cat 2 or 1 while we have her captive here. That's your right SI. That's good. That in there here. Now we're TLing for cat 1. And that seems to be there, huh? So what do I do next with cat 1? If you're thinking back to session 2. Bilateral TL. Which side is the involvement? The hot side, the side you gotta kind of watch out. It's gonna be one or the other SI. Double, two-handed TL. So first she goes like this, and then, yeah, exactly. So we know we got a cat 1, and we'll double up on one side. No. And we go over here. And that's it. So that's the involved side. Now, how do we place our blocks? How do we challenge it? Section 2. Right? So, this is the involved side. It means this is the side that's kind of the lesion. So I'm going to go down here, push behind her ischium here, and under her ESIS here. Press down this way. Yeah. I'm going to press the other way. I use my fist because it's a broader contact, less likely to poke into their tissue with your fingertips. And there we are. So the challenge is this way. How do I put the blocks with category 1? Opposite way. Very good. Everybody agree with that? Everyone concurs? That's true. That's correct. Challenge this way, block this way. Blocks come in at an angle. ASIS, and you're directly in front of the ischium proximity of your wave of the ischium. Now, if I want to be real ornery, I'll test, have the VTL, make sure I got my blocks right. Good. Sure. Now, what else do I monitor with both Cat 1 and Cat 2? First grip tenderness. Is one side more than the other? Right side. Which is interesting because this is the involved side. So, once again, I would probably have them breathe, but that helps relax them into the blocks, into the treatment. Springy, springy, springy. I talk to them about something that relaxes them. Sometimes I say, well, how's the grandkids? Oh my God. One of them's in jail. So that was the wrong. How's your husband? Man. Wrong subject. How are the dogs? Oh, we got a new puppy. Chewing up everything. Once again, wrong subject. Do not talk politics with your patients when they're trying to treat them. Whether you agree with them or they agree with you or not, just that is not a healthy thing to bring into the discussions. Now, let's see what we got. Those are weak. That lesson here. Now, bilateral TL again. Back to where just starting TL. Doesn't show. Take that away. We'll double check to make sure we don't have a cat 2 that's been lurking in the cat 2. So I'm happy with that. So that's category 3. Yeah, you can leave it. Kind of like, yeah. I mean, you want to keep monitoring your indicators. Tenderness, muscle tests. It should clear. I mean, that's about a typical time I would spend doing walking for cat 1s and 3s to take a look. If they don't clear though within a couple minutes, even with fiddling with the custard and all that, then maybe your blocks aren't right. Maybe there's something. That's something I need to correct tomorrow. I need to unswitch myself with regards to my folder here. There's the correction. See, I put the block in. This is where it gets tricky. So a lot of times you'll have weak muscles associated with the cat. Sometimes you don't. But often if you have weak muscles and you put these blocks in, you've got the blocks right, those muscles will facilitate. Well, then you ratchet the lower block down until the muscles go weak. Now, if they never were weak in the beginning, you do the same. You go down until they go weak. Well, then you let it sit for a bit, and usually the muscles turn right back on. You let it cook. When it's done cooking, correcting, both those hamstrings will go weak. And then you're done. You monitor the tenderness. This was for cat 3, but you monitor the tenderness right at the parasacral area. Yeah.
So you said to find it, you would foster it because you really have some showing, but what would be another way?
You have to challenge for it. If somebody's got pelvic low back pain, I'm going to check them for cat 1, 2, and 3. I'm going to check them for disc. Check them, it doesn't take me too long, but I'm going to check for all of it. So I will find them without them presenting posture. I don't find that postural presentation that often. Usually when I do, they're usually like this. This is a disc, and this is more of a cat 3. But if they have a cat 3, they've got a disc because the derangement is happening between L5 and L6 at the disc level. We won't go over. This is where you incorporate the sacrotuberous and sacrospinous ligaments, and you use the SOT correction. We won't go into that. We can do that, but right now I don't want to complicate our thinking. Trochanteric belts. I'm a big fan of those. I used to use them more. So those can be really helpful. Chronic SI problems, cat 3. The one that the best one out there is I think it's, what's his name? It's Soroil or something like that. The guy's name starts with an S. See if I maybe I can get. But he makes a really nice belt. It's comfortable. And then, of course, if they've got chronic pelvic instability, cat 2, cat 3, whatever it might be, cat 1, you got to start looking at their ligament integrity. You got to look at what they're eating, core strength, maybe their abdominals are just not showing up for them, and these things don't just happen. So tomorrow we'll do hidden cervical disc. What time? How much time we got? 5 minutes? 9 minutes. Okay. Anybody got neck trouble? Chronic neck. This will be our last and final thing of the day. Have you had neck whiplash? So we do all kinds of stuff with necks. I just first want to see how the scalenes are doing. So good. So good. SCM, really good. SCM, really good. Head back. Oops. So scalene's a little off. That's a good thing to kind of start with. Make a fist and roll it back. Right? So make your fingers come up. Pull down. So not real strong there. Make a fist. Okay, so one of the classics is wrist extensor weakness and also long head tricep weakness. Definitely have that. So, so you got neck pain. You got a history of neck injury. You might have radiculopathy. You might have some pain going to the shoulder. Do you? Yeah, big time. Okay, that's now. First thing you can do is have your patient with their left hand TL the anterior cervical, flat. Now you're also TLing the carotid. So be aware of that. Now make a wrist and hold. Ah, we got lucky. I see these all the time. I probably had 4 or 5 this week. Yeah, see the difference? She's just TLing that. I go down just a half an inch. Go up, above. Go back to where we started. I do the finger extensors and the wrist. Sometimes the wrist is, yeah, so that, keep that there. That. Take your hand over. So that's a classic presentation. You guys with me? With me or against me? Now, if I find that, then I go to head and neck into distortion. I can feel that. It's just not a happy neck right there. So I'm going to turn you in such a way that we're reducing any anteriority on that right side. Okay. So keep that right there. And that turns it on. Turns that on. So this worked the same that the TL did. And I'll use both because I like all the verification I can do. She's got a hidden cervical disc. It's not so hidden. Now, can you TL that again? Head forward. Let's see if it affects. Yeah. Brightens up those scalenes a little bit. Now, this is a money move, I'll tell you. I have helped more chronic neck, shoulder, arm, wrist, elbow things with this. I wasn't taught much about anteriorities in chiropractic. It was all T to A stuff. It's this motion palpation model. It was, I think, kind of a dark time for our profession when I was going through school. They were getting rid of a lot of the classic chiropractic thinking. Now that actually does TL. Usually it won't TL in the back. Usually it has to TL sort of side front. The weight, lay on your back for me. Now these respond beautifully to respiratory corrections. They also respond really well to good old-fashioned adjusting, but let's try the respiratory first. And then tomorrow, if it's still positive, then we'll get more creative. Okay. Yeah, we got something going on. Now, one of the things to think with any kind of neck instability, scaling, think blood sugar. With all kinds of things, think blood sugar. That's one you really want to chew gum. Don't chew. Don't move your jaw. Challenge, challenge, challenge. Nothing. That's a P to A challenge. Nothing there. Challenge, challenge, challenge. There. Now, read that. So she strengthens on a breath in. Down a bit. So I'm going to do respiratory the same way I would do ostics. I get in, I come in from the other side, and I can show you on the skeleton. I reach underneath and I grab a hold of her D5-6 area here, and I'm doing this. Doing this as she breathes in. So breathe in. Let it go. And breathe. Okay. And give it a tiny nudge. And once again, I'm correctioning with my right hand. I'm doing the correction with my left. It's a little more than if you get it, if you dial in your vector using muscle testing, they should just almost fall into place. Good TL there again. Sit back up. Okay. That moves really well. Now push down. So that's strong and clear. Head turning, no TL, nothing. It's just out here. So that's pretty darn good. Now, Dr. Francis used to do this thing, to do this kind of finishing thing where he would take a dollar bill. I don't have a dollar. Actually, he was such a carrot. He's such a carrot. He would actually use 100 just to be a
You need a dollar?
I think I got a $5 or something. Certainly don't have 100. I can't keep a $100 bill. I just burn the hole in my pocket. So he would do this. This was for laterals. A lot of times they would squeeze. That's pretty good. Should have done this before. Yeah, that's a little bit. Now TL a bit lower. Okay. So lay on your back for me. I won't let you have it, but you really need it. So this, he said, this is for like lateral uncinate stuff that sometimes is. So I'm going to come in through here and just do a real gentle. Okay. Quite so gentle, but it moves really easy. Not too bad. It requires some pretty fine motor. Oh, that's good. What's that? Oh, recently? So that's, we'll see how that does. I mean, I know it's a kind of a long term, it's been a long-term problem, but it's that right now your function went from here to here, just with that one adjustment. Any questions on that? Hidden cervical discs are money. They are money. Learn how to test them and yeah, they are. Because everybody's adjusting P to A out there. The physical therapists are starting to adjust now. A lot of the chiropractors, it's all P to A, and they miss these. And these are as common as P to A fixations. So we're at 4:30, 5:30. What's Quentin time? 4:30. What's that? You made it. Good. Good idea. Okay, so we covered a lot of big ticket items that I needed to present this weekend. And tomorrow we got a few more things, but we can really drill down and maybe start integrating more, between all these things. We're in fourth session. I really want to start seeing you guys put these different things together. And we'll try to talk a little bit about, kind of give you some quizzing about, what to expect. I mean, the exam's not for months, but it'll help you know what to focus on and what to. Thank you.
Thank you.